Hello everybody. I was thinking about how to present this topic so it would be clear. At first I wanted to show everything on the diagrams, but I realized you will get confused because even some doctors get confused. Then I wanted to show it on a plastic skeleton, but showing the development of a joint, especially as complex one as the hip joint, with a rigid plastic model is also difficult one, because developmental movement in this joint occurs in different planes. So today we will have a video called Crazy Hands. We will watch and show everything on a plasticine models and see how the joint develops after birth and during childhood. So first, the pelvis consists of two pelvic bones which connect to the sacrum and with each other. Two bones, right and left. Each pelvic bone consists of three parts at birth. At about 5 to 6 years old, they start to fuse. I will show you how. So if we take this model, we will take right pelvic bone that is oriented roughly like this. The only thing is here will be bigger curve on the red part of this bone. So red one is the pubic, blue is the ilium, and green one is the ischium. How to find landmarks on yourself or on another person? The very upper edge of the ilium can easily be palpated. That is the most protruding bony part located on the lower lateral abdominal wall. Actually, if you go along the lateral wall of the abdomen from the top to bottom, you will feel this protruding tubercle in the lower part of the abdomen. This is the most prominent point of the ilium. So that is one. To find the pubic bone, you go down along the anterior abdominal wall. We follow the muscles. We go below the navel, so muscles, and here you are standing on some or stopping at some bony part, and this is the pubic bone. Here will be connection with the left pubic bone, the pubic symphysis, and third one is ischial bone. The landmark is the ischial tuberosity. These are the bony bumps on which we sit. It is also very easy to find that bony part on which we support ourselves when sitting. By the time of birth, this E-shaped cartilage is not bony. It's actually a cartilage, and it doesn't ossify. It is not ossified by the time of birth, and after 5-6 years ossification begins between these three components of this big bone, and somewhere around by the age of 17 or 18 the system is completely fused and stabilized. That is, here everything is already bony, all the sutures are bony. Therefore, of course, it is easy to work osteopathically before ossification, and osteopathic treatment, of course, possible after the sutures have fused. Just the amplitude of these changes will be much smaller. And next, these bones, when they fuse, form the acetabulum. I will explain you now about the intraosseous lesion or compression of the pelvic bone. This is precisely the mobility impairment in these three sutures, between the ilium and pubic, or between the ilium and ischium, or between the pubic and ischium. that is either one part or another or third vertical part of that E letter of the cartilage. In any of these components, intraosseous mobility may be impaired, that is, the mobility of the bones relative to each other at the level of the few microns. Osteopaths are able to feel these microscopic movements with their hands and able to relieve tension in any of these zones. By restoring micromobility, conditions for joint development, of course, are improved. Next, when the child is born, the acetabulum is quite flat comparing to the acetabulum of an adult. It is formed in an elliptical shape. Here we see a shape closer to a circle, so it is, I think, acetabulum of an adult. And the joint is formed like the key with the lock. The femoral head fits into the acetabulum. Also, there is a very beautiful structure here in the center of the joint. I will show you now. And it goes from the center of the femoral head. It is the ligament. And inside this ligament there are feeding artery and vein for the femoral head, and this ligament attaches directly to the acetabulum. It is located there and it is slightly folded in a joint, relaxed in some positions, and if we have tension in any of these three sutures of E cartilage, it is clear that the ligament won't be doing well either. It will be in suboptimal conditions and the nutrition of the head will be suboptimal due to tension of the ligament. Therefore, when we osteopathically work on a child with these three components, restoring mobility within the pelvic bone, then the tension in this area automatically decreases and this ligament relaxes, which is of course it is not right in the center, a little bit lower, and then its part exits the joint. So if this ligament relaxes, the condition of the artery and vein inside it improves, and the blood supply to the femoral head and neck also improves, which allows better ossification of the femoral head. But the first symptom of dysplasia in children on ultrasound is usually the absence of ossification centers of the femoral head. When the child is born, the femur looks something like this. The orange is the cartilage, the head, the neck of the femur, and also the greater trochanter. They are made of cartilage, and starting from birth, these components gradually ossify. By 3-4 months, an ossification center should already appear in the head of the femur. If this doesn't happen, we can assume that dysplasia of the hip joint is developing, and this is the earliest sign. If there is no risk of subluxation according to ultrasound, the angles in the joint are relatively normal, but there are no nuclei at the age of 3 or 4 months. We are talking about dysplasia because the joint doesn't have time to develop by this moment as it should be developed. And then we see the difference in the angles. If we look at the axis of the femoral body in newborn and adult bone, and axis of femoral neck, we see the difference. So In newborn, the angle between the femoral body and the neck is approximately 140 degrees. By the age of 12, and in adults, this angle decreases to 120 degrees. From birth to 1 year, this angle decreases by approximately 10 degrees. That means that before the age of 1 year old, the femoral bone passes about 50% of its development, and the next 50%, the next 10 degrees, it gains from 1 year to 12 years. And I will explain later why this slowdown in the maturation of the components of the joint occurs after 1 year. Also, in terms of the acetabulum, when a baby is born, the acetabulum is quite flat. It is shallower than in adults and oriented more vertical. There is an important angle that can be measured on pelvic x-rays called the angle of vertical inclination of the acetabulum. And how it can be measured? First, we draw the strict line tangentially to the edges of the acetabulum. The second strict line is a horizontal one drawn through the lower edge of the acetabulum. And this angle, the angle of inclination in this plane, is called the angle of vertical inclination of the acetabulum. And the same tendency we see during the first year of life. This angle changes from 60 to 50 degrees, and the acetabulum moves like this. That is, to exaggerate, the acetabulum becomes more horizontal, the angle changes from 60 to 50 degrees, but to make it clear, I will bigger movement. And from 1 year to 12 years, the acetabulum also lowers down by next 10 degrees. And after 12 years, this angle is already about 40 degrees. So we see the same tendency. During the first year of life, this component matures by 50%, sorry, and the next 50% of maturation occurs in the period from 1 to 12 years. If we imagine two these combined movements together with first, there is a movement of acetabulum lowering, so the femoral head enters more deeply into the joint fossa. In newborns, the femoral head is immersed into the joint fossa by about 30%. In children over 12 years and adults, the degree of head immersion into the acetabulum is approximately 60-70%. And if combined show this movement, we see what happens. The acetabulum descends, become more horizontal. The cervical diaphyseal angle changes. At birth it's about 140 degrees. That's the vertical joint, the joint of a newborn. First this movement happens, then this movement. If I will show you with my hands, it will be easier. This is the acetabulum, this is the acetabulum, this is the femoral neck and diaphysis of femoral body. And first this happens with the acetabulum and next one with the neck. You see this combined movement, right? The acetabulum mature first and then the femoral neck reacts. If this movement is deficient, that is during the first year of life, either this doesn't occur properly or the angle doesn't become more acute, and in these cases we can also talk about the presence of dysplasia. How does the leg adapt to it? If this component, either the acetabulum or the cervical diaphyseal angle, doesn't mature properly, the knee joint reacts. Usually it happens after a baby begins to stand, begins to walk, because legs start to function under gravitation force. This usually doesn't happen before the age of 1 year, usually after in a period of verticalization. And because the joint remains immature here, these angles haven't developed fully. Perhaps the development of either these or this component or both components is slowed. It varies. Usually the knee compensates. It has to, because the biomechanics are not optimal at this level, and there is a constant weight bearing, and the leg needs to somehow adapt so the load is distributed optimally along the axis of the lower limb, not optimally, which is leading to valgus deformity of the knee. How you can determine if a child has valgus deformity of the knee? Because basically the knee joint is designed in such a way that to some extent valgus is considered to be normal up to a certain degree. We need to draw 3 points. I will show you now. Let's add the patella here because it's necessary in the knee joint. So the child is placed in a standing position. We mentally place the first point on a greater trochanter. This is the most protruding bony point in the upper part of the femur, right here in the pelvic area. The second point is placed in the middle of the patella. I will show you now. It is here. And the third point is placed on the inner malleolus. This is the bone protruding here in the foot area. There is also an outer malleolus, but we don't need it. And we try to draw an imaginary straight line through all these 3 points. And if we start from greater trochanter, follow the knee, and the inner malleolus are crossing this line, so there is a normal leg, and we don't say that valgus is a problem here. If the angle increases and the ankle, the inner malleolus is not on this line, we say that child has valgus deformity of the knees. And regarding feet, since when verticalized, such children with developing valgus of the knee begin to place their feet quite wide when they start walking. The foot begins to respond, and the foot gradually shifts to a flat foot. How should I depict it? Probably like this. Therefore, in all children with flat valgus feet, we need to look at the condition of the pelvic suture and the hip joint. Flat valgus feet and genu valgum are usually a compensation or adaptation for what is happening at the level of the uppermost segment. Next we looked, so we have discussed one plane, the frontal one or vertical one, but the joint is complex, and during development, it makes another movement. We were looking straight ahead, right? That is, we are now looking at the joint directly. If we reverse this system and look at the joint from above, what's happened? First, a child is born. When a child is born, their acetabulum is orientated quite posteriorly. I will separate bones, it will be easy for you to understand. And during first year of life, it rotates anteriorly. So the posterior edge becomes sort of closed or protected. So this movement occurs. The femur is smart. It starts to adapt to this movement and it makes such movement. It makes this movement like this. And if the joint development is going well, this movement occurs and this movement occurs, the second one. And the joint structures are physiologically developing. And if either this component or this component is disrupted, by the way, the angles of this bony rotation can also be measured on X-rays. So we are talking about the presence of dysplasia with lesion in horizontal plane, because the horizontal plane will be oriented here like this roller. That is, in case of dysplasia in this plane, which passes through the joint, there is a slowdown in the development of structures. Moreover, the neck, the head actually are not moving in a space, they simply twist like this. This kind of twisting occurs along the axis of these bones and also along the axis of femoral body or diaphysis. And usually this process of femur twisting becomes more active after a year of life again, when the vertical load begins constant, when a baby starts to stand and walk. If this rotational movement of femur decreasing by some reasons, let's see what's happened with the knee and the foot. So we have lack of rotation here. Here the femur is under-rotated. Then the gravitational load along the lower limb will be distributed unevenly, and this forward rotational movement will be compensated by the foot. Look here. And when these children stand up, they begin to piggy and toy. They walk with a forefoot abduction. Firstly, walking like this, uncomfortable. Also, these children are constantly told, don't do this, walk straight, walk right. They try to walk straight. Plus, when child walks with forefoot abduction, weight bearing is not optimal, and in order to somehow balance this situation, their feet go into valga, and ultimately these children with time go into a flat foot. But they don't have any changes at the knee level, that is, the legs are straight at the knees, but the feet have valgus, or just the heel tilted inward like this from the start, or already flat valgus developing. So regarding the joint, probably the main point I have mentioned already, but there are some recommendations for all children, regardless of whether they have signs of dysplasia or not. First of all, don't sit children up until they can sit on their own. I mean that the child should sit up on his own and sit without support. You can't support their sitting with the pillows. You can't actively sit them up and bring them to the state until they are able to do this by their own. You can perform some exercises, of course, but it's better not to put vertical stress on the pelvis prematurely. Also, regarding wearing a baby in a slings or backpacks, when you carry your baby on your arms and he's not sitting upright yet, try not to keep him upright for a long time. Don't carry them vertically. Change the position so he will sit at the angle of 45 degrees relatively to vertically orientated gravitation line. It's clear that we all carry our children vertically. Just try to avoid this to happen too often and too long. Especially in case of dysplasia, because in dysplasia, ossification and rotational movements delaying, it is very, very important. And when a baby starts to stand and later walk, try never to help him and avoid supporting baby with your hands. Your child should stand at the support by his own, should stand without support also by his own, and should learn how to walk by his own only. And parents should avoid to walk a child with their support. Later I will say why. Because the main thing, it is important for forming a proper motor map of the body in the brain of child. Because if we start to support the child with our hands during walking, a baby will develop an incorrect motor stereotype, and such children often walk tiptoeing because gravity force shifting anteriorly. Lately, at the age of 3 or 4 years, such children start to demonstrate to walk tiptoeing. This is very common. Neurologically, they are fine. It is just their parents mishandled the verticalization period. And next, before child learn to stand up, we always recommend prolonged period of crawling, stimulating the child in every way possible, leaving them with bright and interesting toys at the floor, brightly colored objects, whatever you want to stimulate them to crawl as long as possible, and let them stand up later. Children with dysplasia usually start to walk a little bit later, and it's okay. It's not retardation of development. We just don't train this skill earlier than it needs for the body. Why crawling is so important? Because this alternating screwing movement is performing in a joint while crawling. The femoral head is going anteroposterior, and it's quite safe. And do you see this screwing movement in a hip joint? And in this position, the femoral head is maximally immersed into the acetabulum, and all the vascular and ligamentous structures are maximally relaxed. Since child start to stand, all structures are tightened. Everything now is in a state of maximal tension, and this is one of the reasons why after a year, when a child can stand on his feet, the formation of all the angles in the hip joint slows down. It's quite logical why a child is lying on his back, on his side, or prone while he is crawling, while he's sitting. His body doesn't experience that vertical load, and there is no tension on the ligamentous and vascular structures. And as soon as he stands up, everything is getting strained. The nutrition of the joint deteriorates, and the potential for maturation of joint structures is diminished. And such children who didn't have long crawling period and didn't have osteopathic help during first year of life can manifest with any symptom usually much later. but almost all of them have a very rigid pelvis, meaning these intraosseous sutures don't work properly. We often find femoral strains, knee, ankle, and whole body problems. If a baby has a splint on him, hips are flexed and spread away, and in this position you see that the head is also deeply immersed in the acetabulum and fixed in the anterior inferior position in the joint socket. This is the safest position for the femoral head because there is no risk of slipping. If there is risk of subluxation, look what is happening in the joint. The upper slipping movement, in such cases the roof hasn't lowered properly. It stays vertical like this. The roof is the upper part of the acetabulum, and here, yes, there is such a big angle, so the entire system is unstable. Why is the risk of upward displacement? That is the weakest direction in the joint, and femur goes up here. That is why the position for the joint when the baby's legs are straight, it's the most unsafe, and when we bend the legs and spread them apart, then we move the femoral head from this position into this position. For this reason, wide swaddling is better for children, because when a baby is tightly swaddled, their legs are straightened and they don't have the opportunity to perform natural movement, which are necessary for maturation of the hip joint. Watching babies at the age when they are able to sit, you will see that their hips often rotate outward. Moreover, before the age of sitting, their hips usually flexed and abducted and flexed. This is quite logical from the point of nature, because these positions allow all described structures to develop optimally. Therefore, when standing up, when the baby is already vertical, there is much less opportunity for maturation of the joint structures. So, regarding swaddling, wide swaddling is much more beneficial. With wide swaddling, usually small pad inserted between the legs. I will show you now on this doll, like this, and in this position, even if the baby tried to move his leg, first his leg isn't vertical, it is slightly outward rotated and abducted, and also there is at least some space there around his leg, and he can move it a little in his sleep. And when we straighten his legs and tighten them, that is, all the structures are straightened and they are very taut. What kind of joint maturation? Well, obviously the condition are much worse. We describe, I guess, main topics about small children. Well, these moments are very important because the pelvis is the foundation for spinal development. It affects not only the legs, it affects the entire body. We have looked at the situation that arises after verticalization and before verticalization. If we have rigid pelvis, usually baby demonstrate hyperextension of the body when lies on his back or on the side or in prone position, and such babies can create the illusion that they can hold their head up very, very early. Or there is a twisting pattern throughout the body to one or to the other side, and it is usually diagnosed as torticollis. Often in such cases, osteopathy working with the pelvis without even touching the neck, the torticollis goes away. So those are the main points. I hope all was clear for you today.